Everyone. I am Aubrey Rhodes. I have the privilege of serving as the Lung Cancer Research Foundation's Executive Director. Our mission here at LCRF is to improve lung cancer outcomes by funding research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. Before we begin, just a quick reminder, we ask that everyone stay on mute for the call, and we remind you that the chat is open, so feel free to share any questions or comments that you have there. You can also introduce yourself and share where you are in the world. The captions are enabled today, both in English and Spanish. You can turn those off in the settings if you'd prefer not to have those. And we also ask that you not ask personal questions about your own personal health care during this session. If there are other things that you need to talk about afterward, we would be happy to connect you with the doctors. So at LCRF, research is our middle name. It's where we put our energy and it's where we focus. In fact, just last week, we announced that we will be funding nearly $4 million in new research awards, which we're incredibly excited about. But today, we're here to talk about the latest in lung cancer research. So we're going to be covering a wide range of topics around really the hottest topics that were presented earlier this month at the American Society of Clinical Oncology's annual meeting. So we do want to thank Regeneron for their generous support in making today's program possible. And with that, I want to turn it over to Dr. Isabel Preeshagul, who is an assistant attending on the Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center and our moderator.
Thank you so much, Aubrey, for the introduction. I am thrilled about the direction LCRF is going. That's so exciting about the opportunities we have for funding research in the future. I am so excited to be here, joined by our two incredible guests, thoracic oncologists. I am honored and excited to learn from both of you today. I'm going to go ahead and introduce them because we have so much to dive into. I'll first start with Dr. Zofia Piotrowska. She is an attending on the thoracic medical oncologist at Mass Gen Hospital and an assistant professor of medicine at Harvard School of Medicine. Dr. Piotrowska's research is very much invested and focused in understanding the mechanisms of acquired resistance to patients that have non-small cell lung cancer with driver alterations. She also received her MD from Yale University of Medicine and trained in internal medicine at the Brigham and Women's Hospital and hematology oncology at Dana-Farber Institute and Mass Gen Hospital. Dr. Piotrowska, we are so excited to have you here. And we also have Dr. Nisha Mohindra. Dr. Mohindra is an associate professor in the Hematology Oncology Division of Feinberg School of Medicine at Northwestern. She is a 2019 LCRF grantee, so congratulations on that and the work that transpired from that award. Her research interests focus on clinical investigation of novel agents or combination therapies for non-small cell lung cancer, as well as small cell lung cancer. She is interested in developing quality of life and economic research as it relates to immunotherapy and lung cancer as well. So welcome to both of you. Feel free to say hello and introduce yourselves.
I can start and just say thank you so much. Thanks for the nice introduction. I'm really thrilled to be here. I've done this program before, and it's really great to have the opportunity to chat about the data and to interface with everyone. Great to see some familiar names in the participant list too. So hi, everyone.
Hi, I'll echo what was just said. I'm excited to be here. There's so much to talk about, which is exciting and tells us where we are. And excited to hear where LCRF is going. I was a grantee at one point, and so really appreciated, the support that comes from this group. So excited to be here.
Well, we can't wait to dive into the data, and thank you again both for joining me. So we're going to really be talking about small cell and non-small cell and some new approvals, but let's start with small cell because I feel like it's always left to the end, and there was so much exciting stuff that was covered at ASCO. So I think let's start in that space. So the IM-Forte trial was a trial that was basically looking at frontline chemo and immunotherapy for patients with extensive stage small cell lung cancer. And typically for these patients, we give chemotherapy and immunotherapy, and then we follow with immunotherapy maintenance. But this study was looking at adding lurbinectedin to immunotherapy. And I think it's an interesting concept. I'm going to start with you, Nisha. What were your thoughts about this? And are you going to, adapt this into your clinic? You hoping to adapt it one day?
Yeah, it was exciting to see. I think that the maintenance space for small cell has been one that's been attempted in different ways. And this was an interesting way to see putting, again, an active therapy into the maintenance setting after chemo, immunotherapy, the first 4 cycles, and it did improve outcomes. Um, Certainly, I think we'll have to be thoughtful about patients and understanding how they finish out the first 4 cycles, and because the treatment is effective, but it's not without side effects. I think having that shared decision making, but it did have a benefit for PFS or progression-free survival and overall survival. So I do think it adds to how I think about maintenance for my patients.
Yeah, I would definitely agree. And I think, it's going to be, this is going to be one where I think it's going to be really important to have that conversation with patients. I think a lot of times that immunotherapy portion of the treatment is a time when, the chemotherapy side effects have worn off, and often the kind of patient's quality of life is a little bit better than it is initially when they start on treatment. And so it's tough to take away from that and add essentially a different type of chemotherapy, but at the same time, it clearly can have some benefit. So I suspect it'll be the right thing for some patients, but not all. And I think it'll require kind of discussion and really thinking through what each patient's individual priorities are and making those decisions together.
Yeah, I definitely agree. And I'm always excited to see anything in this space. So, having something that does change outcomes and improve outcomes is important. But lurbinectedin right now is a second line option. So I think, some patients may feel a little bit uneasy that, we're essentially removing an option for them. But, in a way, moving something from the second line setting to the first line setting or maintenance setting is how we move the space forward. So I think, there are so many patients whose cancer reoccurs while they're on maintenance immunotherapy, whether it be the durvalumab or the atezolizumab. And if we can prolong, lengthen that tail and, make them live longer and decrease the risk of their cancer coming back, I think that's huge. But Nisha, you mentioned toxicity. Talk to me about what kind of toxicities you're worried about when we're adding Lurbi in this setting.
You, you know, in my experience, fatigue, neutropenia, are the things that I think about. Um, Again, they did do measures to prevent the blood counts from dropping. They asked for growth factor to be used. I think this space in general, I think what we're understanding overall is can we extend the benefit of the first line treatment and the time between getting that nice response and disease reoccurrence. So I think this is an active space where we will see a lot of new agents come up, and that's what you're going to think about weighing is what does that look like from a side effect profile standpoint? How do I weigh those? But those are the things I think about initially with that drug.
Yeah, I agree. Zosha, anything to add on your end there?
No, I think that's, I fully agree. I think it's really exciting to see, we also know, I think it's also sobering that for these patients, we talk about getting to second line therapy, but sometimes things happen that make it difficult for patients to get on to treatments when their cancer reoccurs. A lot of times, something can happen and patients can get sicker such that, more treatment doesn't end up being feasible. So I think that there's also the thought that if there are effective therapies and you can kind of introduce them earlier in treatment, that can help patients access more therapies. But again, I think that has to be balanced. I don't want to kind of, say today that it's the right thing for every patient, because I think that there are certainly many patients who can do really well on the immunotherapy component of maintenance and have a really, durable response that gives them some good quality of life time, and then, can think about these treatment options in later lines. So again, I think this is one of those things that's going to be right for some patients, but not everyone.
Totally agree with you there. Speaking of second line, just moving on to another study called the Delphi 304 trial, which was looking at a drug called tarlatamab in the second line setting. And tarlatamab is a bispecific antibody drug. Basically, it sort of has two heads, one head that binds to DLL3 on the tumor cell, and another head that carries the warhead or the chemotherapy agent. And I think that there's a lot of excitement about this drug, but we're just not really sure, where it lives exactly. And right now, the FDA has approved, first extensive stage small cell lung cancer, chemo and immunotherapy. And in the second line setting, we have topotecan, we have lurbinectedin, and we have tarlatamab. And as we had just mentioned with the IM Forte data, maybe lurbinectedin will be moving to the frontline setting with maintenance immunotherapy. And that might shine more of a spotlight on tarlatamab to see if this is really where it lives. What has been Zosha, what's been your experience with tarlatamab? Have you given it? Like, how are patients tolerating it? Talk a little bit to me about that.
Yeah, I would say, and I'll be curious to hear what Nisha's practice has been like, but, I think tarlatamab has made a big difference for our patients. It's already a drug that's received accelerated approval by the FDA for kind of, the second and later line setting for small cell lung cancer. And so it's already been a tool in our kind of armamentarium. This study was really kind of trying to establish how does this compare to some of the other tools that we have, like those chemotherapy medicines. But we've already been using it. I think it's kind of got this novel design where it's trying to bring cancer cells together with the immune cells. And I think that overall actually can be a really effective strategy. And the study proves that. I think the side effects and kind of how patients manage is a little bit different than some of the other therapies that we're used to. I think that patients need to know about most is that, this is a therapy that initially, when you first start on it, requires some intensive monitoring. Because when you kind of activate that immune system, when that immune system is stimulated to fight the cancer, sometimes you can have kind of an inflammatory response that we call it CRS, or cytokine release syndrome, that can make patients kind of sick transiently after the first infusion, after the second infusion. So much so that currently the recommendation is actually inpatient monitoring for 24 hours after treatment for the first two infusions, which sounds, I think when we first tell patients about it, no one wants to be in the hospital. But the good news is that once you kind of get past that period, first of all, in that period, most patients actually, even if they have that CRS, it's manageable. Some patients can have fevers. Some patients can have a period of time where they might need some supplemental oxygen, maybe some IV fluids, things like that, but it's transient and then they do better. And even if they have that, afterwards, it usually doesn't reoccur with subsequent treatments. And thereafter, patients can get their treatment in the clinic. And often, they actually doesn't have a whole lot of other side effects, which has been great to see. You can also occasionally get this ICANS or kind of neurologic side effect as similarly early on. And both of these are usually kind of managed with just some steroids and monitoring. And overall, I would say, even though it seems crazy to say that a medicine that you have to be admitted for, once you get past that, patients can tolerate it pretty well. So I think we've already, moved to using it quite a bit. And so I think the Delphi 304 data kind of helped reaffirm that this is a really good option for patients as that second line treatment, comparing it to all these other types of chemotherapies that we're talking about. It was pretty exciting to see, I think a meaningful improvement, not just in kind of how long patients are on treatment, but actually in overall survival. So I think, and again, looking at the safety that they showed in the study, overall, I think it was better tolerated than a lot of the chemotherapy agents that have these kind of chronic side effects. So I'm really excited about this agent for a patient with small cell.
Yeah, me too. I think it's been really exciting to see some of the outcomes that come out even in your own clinic. It is a different way of doing treatment. So I think patients and caregivers, it's learning a new language. It's learning how to monitor patients after they go home after the first couple of cycles. I think there will be work to eventually get this to be much more outpatient. But for right now, it's been a nice partnership with getting family and friends involved in the care and thinking about what that looks like. And again, I think we're learning that there are a lot of other ways to go about treating lung cancer, and this is such a new mechanism for this disease. So I think we'll see a lot more again with these molecules. Like the more that we can help support patients and families with this type of treatment, I think will serve us well for what's to come.
Yeah, I agree. I think I was very comforted by the data, and excited that, that this is an option for our patients. Interestingly enough, just as an aside, you both highlighted the fact that day 1 and day 8 of this infusion do need to be given in a hospital setting, and that's because of the risk of cytokine release syndrome. And obviously, we want to watch out for ICANS, which is, as Zosha said, the neurological side effects that can happen from this infusion. But we do have a study at MSK, basically focusing on a concept called a hospital at home. And basically, yes, basically what it doesn't mean that you have a whole hospital set up in your house. Basically what it is if you were to have extensive stage small cell and you were to have, unfortunately, your cancer progress on frontline treatment, and you decided to enroll in this study and you were a candidate for tarlatamab, you would get randomized to one of two arms. One arm would be standard of care arm, where you're getting tarlatamab in the hospital. Day 1, you go there, you get your infusion. If everything goes okay, you go home, and then you get readmitted a week later for day 8. And it's the same process. What this does is Instead, if you get randomized to the hospital at home arm, on day 1 and day 8, you would get your infusions closer to home, and there would be a paramedic that pars with where you are. And it depends if you're getting treated in our network or closer to the main campus site. But basically, all of the monitoring would either be done in a hotel close to the main campus hospital, or we would par with a paramedic, and the paramedic would be coming to check your vitals wherever you are to make sure that, you're not developing any fevers or any early signs or symptoms of cytokine release syndrome. And you're given, you're equipped with you also have a home pulse ox monitoring, and these paramedics have been trained in evaluating and identifying and managing cytokine release syndrome. And we also ensure that you're near a facility that has tocilizumab, which is an interleukin inhibitor that we use to treat patients that develop cytokine release syndrome to decrease the inflammatory response that the body has. So we're working towards trying to figure out if it's safe and manageable and possible to give tarlatamab in the outpatient setting, because I will tell you that's, from my experience, and I would love to hear from both of you, a reason why certain facilities and institutions are not adopting this into their pharmacy. And patients are coming as second, third, fourth opinions to our institution to get tarlatamab because it's not offered where they are. So maybe if we could figure out how to give it safely in a home environment or outpatient setting, maybe these kinks could be ironed out and it would be approved. Are you both seeing various opinions for this?
We definitely are. And I think you're exactly right. I mean, I think this is an opportunity, there is a certain kind of level of comfort, I think, in a bigger academic hospital for that initial monitoring. And then, as I was alluding to earlier, afterwards, patients can do well. So I think there's some opportunity for partnering between smaller hospitals and bigger hospitals here, but definitely, that's inconvenient and hard for patients who have a relationship with a team already, and then having to kind of go and meet a whole new team can be a lot. So I hope that in the future, kind of home hospital, home monitoring, or even, kind of longer monitoring in infusion centers will change how we're doing this. And I think we're all starting to get more and more experience and comfort. And that data that, from trials like what you're describing will be so important.
Yeah, I definitely see that either people are coming for just the first 2 doses, and it is getting established with a new team and then getting back to your home team. So it is taking some coordination and may cause delays, or people are waiting to later lines of therapy. And I do think this is a promising drug, and would like to use it earlier when people still are fit. So yeah, excited. Keep us up to date, and maybe more of us can join you.
Yes, well, think of our study. If you're at an institution that's close to MSK that's not offering tarlatamab, or if you're willing to make the trip, I know that this study has lots of resources, and we at MSK have resources, also philanthropic funds to work with you about, any barriers to getting on trial, housing, transportation, whatever it may have you. So please keep that in mind and don't let that be a limiting factor.
And I think this concept of the home hospital is something that's really kind of being rolled out in lots of different settings. So it may sound crazy in some ways, I imagine, for patients to think of, having that level of care in your home. But I mean, at MGH, we're seeing that applied in certain situations for patients who need to be admitted to the hospital. Every hospital is overstretched. Emergency rooms have too many patients. So I think this model is something that we're all growing increasingly comfortable with, and it allows patients to get really high quality care in their home environment. So I think don't let that kind of idea scare you off, because I think it is really forward thinking and will be how we practice in some situations going forward.
And not to do too much of an aside, but I think the concept of decentralized clinical trials is a very hot topic. And I know we're not talking about that today, but this is basically the concept of being able to be on a clinical trial when you're not very close to the institution, and figuring out how we can monitor you wherever you are. So it's just increasing access to care for our patients, which is an area that's very near and dear to me. And all of you, of course, on this call. So I think we're hopefully making moves in that space. So we're going to move away from small cell, and please feel free to still put questions in the chat. It's really picking up the pace, so I'm loving the interactions there. But we are going to move on to non-small cell lung cancer in the interest of time, as there's quite a bit to talk about. So we're going to start in the early stage setting, where there were some great updates on trials that we have in this space. I know one of the main trials that we had some survival updates on was the Checkmate 816 study led by Patrick Ford. And this study was basically looking at giving patients neoadjuvant chemo, which means chemotherapy and immunotherapy before they go to surgery. And there's lots of benefits to doing this. One is prehabilitation. One is, patients are more fit before they go to the OR. They're not worried about like wound healing, and they're not worried about delays. And it's a nice way to kind of take a look at the tumor when it's taken out of the body after it's been exposed to chemo and immunotherapy, to see how much of it is viable or how much of it is still a live, active tumor. So this study actually had many outcomes and many endpoints that are highlighted year after year, but there was exciting overall survival data in this space, which I think we love seeing in patients that we're trying to treat with intention to cure. So Nisha, I would love to hear from you about what your thoughts are about the Checkmate data. Have you adopted this into your practice already? How are you handling patients that are coming to you for neoadjuvant therapy?
Yeah, it's a great question, and it was exciting to see, the overall survival data and the updates at 5 years. So when patients come to me for neoadjuvant therapy, I think that there's this concept of, are we doing the treatment only prior to surgery, or are we also doing additional treatment after surgery? And I leave that as a plan that we will be determining together over time. So I do kind of lay out that paradigm of perioperative approach, where you do some treatment prior to surgery, then surgery, and then additional treatment after. But I think that what this trial showed was that, these 3 cycles with chemo and immunotherapy improved survival compared to chemotherapy alone. And, it had a nice absolute difference in overall survival. So that was a really promising thing to see. I think what we still don't know is how to think about patients after they've had their surgery, and we're looking at their tumor tissue, and what degree of clearance of that tumor tissue in the surgical specimen tells us what to do next. Are there any things that we would do to escalate treatment? And that's a really big question in clinical trials. Do you continue with the immunotherapy that you were using before? So I think I think this space again is showing that we're benefiting patients, we're making them live longer, and that as we grow, we're starting to understand that there are more nuances that we all need to think about when we make that decision. And sometimes, in historically, when I was trained, you made that decision before you did any treatment. But I think what we're learning is that you take it as you get information back from the patient as well as from the surgery. But yeah, I'd love to hear how everyone else is approaching it as well.
Yeah, I agree. I think, a challenge that we're facing here, and I mean, I think this is a challenge we frequently face, is we have a lot of different studies that are all positive, but we can't directly kind of compare which among them, which is the best option, right? This comes up all the time in every context in cancer care. And so we have, positive studies that have shown improvements in outcomes and especially in overall survival with kind of that perioperative, preoperative, chemoimmunotherapy, and then, surgery, and then after surgery immunotherapy, that's shown to improve survival. And now we also have just the preoperative part showing, improved survival when you're comparing to kind of the old standard of just chemotherapy alone. But it's hard because I think we can't directly say which of these approaches is the best. And so we have to really, personalize a decision. I think Checkmate 816 has a few advantages. It's a shorter time of preoperative treatment. It's 3 cycles instead of 4 cycles. And it doesn't commit you to kind of that after surgery approach. But at the same time, for some patients, you kind of want to leave that option for the adjuvant, the post-surgical immunotherapy as well. So I think they're both reasonable options. I think that we are having to really kind of make decisions as patients are going through these therapies, both in terms of how they're tolerating the treatment and then what happens critically at that time of surgery. That visit after the surgery when you're reviewing the pathology report, I think is really important. And for now, I hope in the future we'll have better studies to tell us how can we, be more informed and selective in how we choose which patients really need that extra immunotherapy after surgery and which patients are going to do just fine without it. But for now, I think we have to kind of live with the data that we have and just try to make the best and most informed decisions for each patient.
Yeah, thank you both for your insight there. I think you hit the nail on the head that we used to decide before, and now we're deciding during and after and a little bit before. And it's an evolving process, which is, I think, very frustrating for patients because they just want to know, most of the time, from my understanding, what's my plan? How can I get back in the driver's seat so I know what's ahead? And if you're just kind of like, I'm still not sure, we need to wait for this, they're just like, it's one hurdle after one hurdle. There was a subset analysis from Checkmate 77T, however, that did look at who really benefited from sandwich therapy, which means a little bit of chemoimmunotherapy before surgery and then a little bit of immunotherapy after. Or the sandwich approach is also known as perioperative, and these terms are so confusing, right? So perioperative or sandwich approach is a little before surgery and then a little bit after. And then neoadjuvant therapy is just treatment before surgery. So what all of us are talking about today is trying to figure out who needs only treatment before surgery and who needs the sandwich approach, right? So there was a study called Checkmate 77T, which looked at chemo and nivolumab or immunotherapy before surgery and then nivolumab after. And that study is very similar to Checkmate 816, which is just looking at chemo and nivo before surgery. And that Checkmate study did a subset analysis to see, who were the patients that really needed a little bit more immunotherapy after surgery, who needed more treatment. And it seemed like it was those patients that had low PD-L1 and did not achieve a complete pathologic response, which means that when the tumor comes out, complete path response means there's nothing alive. There's no viable tumor. It's just big dead tumor. And it was basically the patients that had a lot of viable tumor left and that their PD-L1 was low that needed a little bit more immunotherapy after, or they did a little bit better. So are you using that sort of subset analysis to kind of, I guess, gauge these discussions or formulate these discussions with your patients?
I definitely think that, I think across all these studies, we've definitely seen that the patients who have that pathologic complete response, it's called, which means, when they look at the tissue under the microscope, there's no more viable cancer cells. I think those are the patients that we feel most hopeful and best about, right? That they've really had a great response. And I think one question is, for those patients, do they need more treatment? Or really, could we be happy? And, we know that really no matter what we do with those patients, the likelihood of recurrence is much lower if you have that path CR, it's called. On the flip side, I think we worry when we see that tumors haven't had much kind of decrease in viable tissue and there's still residual tumor cells. Now, that being said, there's a gradient, right? Sometimes the patients will have a lot of viable tumor cells, sometimes just a little bit, and that hasn't necessarily been really kind of quantified in the studies, and we don't really know what to do with that. I think a challenge with that is we know that those patients probably have a higher risk of recurrence for these studies. But right now, I think that it's also telling us the treatment, the chemotherapy and immunotherapy that they got before surgery didn't work as well as we'd like. And all we have right now is to say, let's give you more immunotherapy and let's watch closely. And for most patients, I think that's the right thing. But here I would highlight, I think this is a huge space where there's, kind of a push to do research and to try to develop different strategies, because I think the idea that perhaps you could introduce other therapies that the tumor hasn't seen yet, to kind of augment that response and to help those patients do better is going to be really important. So I think those are particularly patients where we should be thinking about, are there kind of new approaches that we could take? But it is something that I think most of us are using as a big decision point. And I'll also say that even for the patients who do have that pathologic complete response, we don't know. I think there are many situations, if they're doing well, we'll say, maybe we should keep going with the immunotherapy. You had a great response, maybe giving it. So it's not to say that they shouldn't, but we feel hopeful that, whether we do or don't give them additional treatment, they're the ones that have the best kind of likelihood of good outcomes. But I think these are hard decisions, and we need more data and more, I think, new approaches to be able to really kind of give the patients the best outcomes that we can.
Yeah, I'm using that pathologic response to help dictate what we think about after. But I agree. I think this is going to be such a big space to say, if there is a lot of tumor that's still there and active, would I be able at some point to have a trial that could add something more? And for those that have completely, their tumor is no longer present in the tissue, while they have really great outcomes, it's not 100%. So again, just what is the right approach? And I'm hopeful that, we will have trials that are going to help us answer that over years. But yeah, I am using that as a decision maker, or at least a big conversation piece along with the patient and what their preferences are.
Yeah, I think it's obviously these visits where we used to be able to have, one option and the discussion was we do this or we don't, is really becoming much more nuanced, which I think is exciting but complicated for us how to navigate, and even more so just really challenging for the patient to figure out, well, what's right? Like the doctor doesn't even really quite know exactly what's right. How do I know what to do for myself? So I'm happy to have options, but it just adds more complexity. I agree. Go ahead.
Oh, I was just I don't know if in the interest of time, we have time to go into it deeply, but I have had a few patients ask about this. So I think it's maybe worth just mentioning this idea of MRD testing or minimal residual disease testing as kind of an added tool. And, again, I've had a few patients who even since ASCO have kind of come and said, is this something we should be doing? So maybe it's on some of the audience's mind, but, it's this idea. I think many of you have heard about the concept of liquid biopsies or kind of doing blood-based testing to look for cancer DNA. That's something we do a lot for patients with more advanced cancer as a way to look, do the molecular testing that we need to do. But there's also ways to do kind of very sensitive testing to try to find fragments of cancer DNA in the bloodstream in patients who are having, earlier stage cancers who are getting this type of treatment with the goal of eradicating the cancer. And, we saw some data at ASCO, and we've seen in other contexts that if you look at MRD, if you look at a blood test and you can detect little bits of cancer DNA before and after surgery, if patients have residual kind of MRD, cancer DNA on that MRD test after surgery, that's probably a higher risk marker than if they don't. And that seems to correlate again with outcomes. So I think that's another tool that we might use in the future. But I would just say, I think there's still a lot of unanswered questions about how to incorporate that into our practice. And I think that's important to say because, there are MRD kind of assays out there that one can order. And I've had patients ask about it, but it's hard because we don't really know which is the best test. They have different kind of characteristics. They have different levels of sensitivity. And so generally, in my practice, I haven't been reaching for those because I also don't know exactly what to do with the results and, you know, what they should mean in terms of both treatment and monitoring. But I'd be curious if either of you have been using them. And someone just put in the chat, they're also not covered by insurance, which is another huge barrier because they can be very, very expensive.
Yeah, I have had a few patients ask about this, and we've tried to get it done and had it got it approved somehow. But I will tell patients, I'll say, you know, the technology is emerging, and what we want to know is, you know, what does a negative mean? And is it a true negative, or is that the best the test can detect at this time? So I always take it with a grain of salt. I say it may be complementary with our imaging and other ways of surveillance. It wouldn't be the only thing I did, but again, we've like you say, we had a positive, and again, what do you do when there's not really evidence of disease on the scan? So before I engage in that and make sure we know how we might interpret the results, both positive and negative, and will that uncertainty, if there is a positive but not disease, will that also be something that will be hard for a patient to deal with? Because again, these are emerging, and how do we use them best is still to be determined. But I do think that they will be a tool in the future of, you know, even before surgery, after surgery, and throughout the time course. But we do have to be able to find the right assay.
Zofia, thank you for bringing that up. I'm very glad that you did. It was on the agenda, and I'm so glad that we talked about it. I've been asked about it also, and I think not only in the curative intent setting, following ctDNA or MRD, which stands for minimal residual disease, detecting that because of that data that came out that showed that patients that essentially after they got chemoimmunotherapy before the OR, if they cleared their ctDNA, they may do better. I've got lots of requests about that, but I don't really know what to do with the data. And I don't know the exact cost. I think it depends on your insurance and the panel that you use, and each panel has different sensitivities, and we don't know what to do with the levels. So I've not adopted it yet because I'm just fearful that I'm going to interpret it wrong or just make a decision that's not safe yet. But I may use it in the future.
You know,
yeah,
I think
it's not.
You know, it's really something that's only for now being done on a research basis.
Yep.
Yeah.
Totally agree.
So we were just talking about chemo and immunotherapy, which is used for patients that do not have any driver alterations, meaning they do not have EGFR alterations and they do not have ALK fusions. We can use those cocktails for patients with KRAS alterations and HER2 alterations, ERBB2, not EGFR HER2. So there are certain patients with driver alterations that can receive immunotherapy, but not patients with EGFR or ALK fusions at this time. So you're probably wondering, well, how can we talk to our patients that have EGFR alterations? Can they not get neoadjuvant treatment? And that is not the case. Actually, there was some beautiful data presented by Dr. Jamie Chaft on NeoAdora, which is looking at giving osimertinib, a tyrosine kinase inhibitor that's approved in the adjuvant setting, meaning post-surgery, and also approved after concurrent chemotherapy and radiation, and also approved in patients that have, unfortunately, stage 4 disease, but it's never really been used before patients go to the OR until this data came out. I'd love to hear from you, Zofia, and also Nisha, about your thoughts about this.
Yeah, I was really excited to see this data because I think, as you highlighted, we've really been in a challenging situation. You know, we do testing. We know that for patients with early stage disease where we are considering going to surgery, that testing for these mutations is important because we know that, for example, if you have an EGFR mutated lung cancer, we know from more advanced cancers and many trials that immunotherapy is not as helpful and that it can actually impact your ability to safely get that osimertinib drug after surgery, which we know you need. So then, you know, these were very long discussions in our tumor boards to say we have a patient who, you know, has a potentially resectable cancer, but the surgeon would like us to give them some treatment before the surgery to help kind of shrink the cancer and help give them the best outcomes at surgery. And then the question was, what should that treatment be? Should we be thinking about adding osimertinib before surgery, knowing that it can help cancers shrink well? Should we be thinking about chemotherapy? Should we be doing both? Sometimes should we, we would say, well, maybe we should just go straight to surgery because that's going to be the best approach. So, it was really, I think we did all sorts of we would take different approaches for patients, but we really didn't have data to guide us. So I think the NeoAdora study was really welcome in that setting. It was a very nicely designed study. There were basically 3 arms. Patients get either chemotherapy alone before surgery, they could get osimertinib, the EGFR oral inhibitor alone, or the combination of EGFR inhibitor plus chemotherapy. And the primary kind of endpoint that they were looking at in this analysis was what were the rates of tumor regression at the time of surgery, something called major pathologic response. Here, I'll just say that, we know that with these tyrosine kinase inhibitors, for whatever reason, the likelihood of having that pathologic complete response where you don't have any viable tumor cells seems to be less likely than we talk about it with immunotherapy. So, we're happy to see patients who have kind of a major pathologic response, which means less than 10% viable cells. And I think if you had asked me before this presentation was given, you said what would be the likely outcome, I would have thought that maybe the combination of osimertinib and chemotherapy would be the best, and then osimertinib thereafter. And what I think was surprising is that they actually performed relatively similarly. The arm of patients who just got basically 2 months of osimertinib before surgery, and those patients who had osimertinib plus 2 cycles of chemotherapy. I think it was 2 cycles chemotherapy before surgery. And they both did much better than the patients who only got chemotherapy without an EGFR inhibitor. We saw, the major pathologic response rate was in the high 20% range with both of those arms. And so, I think that it's certainly very intriguing and encouraging data. I think it helps us have some sense of what the right thing for patients is. I think it doesn't necessarily answer which of those 2 approaches is best. And it's important to say that the study wasn't designed for those to be compared to head. Each of those arms was only compared to the kind of control arm of just chemotherapy. So we can't directly make comparisons between chemo plus osimertinib or chemo or osimertinib alone. But I think in my practice, I think that probably both are reasonable. I think a lot of these patients kind of with stage 2 and higher cancers we're going to end up wanting to give them chemotherapy after surgery anyways. And so I think there probably will be some temptation if patients are kind of well enough to have it to give them the combination. But then there may also be some patients where we decide that osimertinib, upfront is right. Of course, this is not approved yet. This is not something we can do in standard practice quite yet, but hopefully it will be. And I think it's really exciting, and it gives us some answers to these questions that we really haven't known, prior to this data.
Well, Zofia, you answered it so well. No, I think it tells us that osimertinib should be used in the neoadjuvant space, and whether you do it with chemo or alone, I think that will be, again, at the discretion of thinking through the stage of the disease and maybe getting some longer term survival. But I think this was nice. And I think I also highlighted that we have historically been using chemo alone pre-surgery, and just it was humbling to see that doesn't have as much tumor regression as I think I had even hoped for. So I think osimertinib prior to surgery with or without chemo is what I will be adopting when it gets approved. And
I'm going to put both of you a little bit on the spot here just to ask your thoughts, just because I actually struggle with this myself. So let's say you see a patient, very fit, candidate for neoadjuvant treatment with an EGFR alteration. Are you giving OC up front? Are you giving OC and chemo? And then how are you planning what you do in the adjuvant setting after surgery if they had, maybe nodal positive disease still? Walk me through how you would manage that.
good question. So it's extrapolating data from different pots. So in Adora, there was a little bit of data that said the patient that had chemo before osimertinib may have some advantage. So I think for my nodal positive or and stage 3 patients, I would consider chemo osimertinib, but I don't actually know that there is a right answer prior to surgery. I don't know. I don't know, Zosha, if you have a different approach or if there's other
No,
considerations.
I think, I'd be tempted certainly for a patient who's well and fit and we think can tolerate kind of the chemotherapy and osimertinib combination and get through it and get to surgery. I think that's certainly tempting. Again, we have to remember that the old standard was surgery, and then if patients had bigger tumors or node positive disease, then they would get chemotherapy after surgery. And then now in the past 5 years or so would also get, and continue to get osimertinib for 3 years after surgery based on, results from the ADORA study that we saw a few years back. So we already know that they kind of need all of these components. So I think that moving some of that chemotherapy to before surgery is appealing. I think we're used to doing that now from, in all of our patients from all of these chemotherapy and immunotherapy studies. So I would be tempted to do a combination. And then afterwards, think about the kind of adjuvant portion of osimertinib. I think that's still the right answer. Even if patients get a little bit of it before surgery, we should still be giving it to them after surgery based on the ADORA trial. But again, I think that it's a discussion, and it's a discussion with the patient, but also very importantly here, I think it's a discussion between the oncologist and the surgeon, because a lot of times there's nuance here to what the surgery is going to entail, what, kind of what type of surgery, what extent of surgery. And sometimes there are situations where if the tumor shrinks, it can impact the kind of extent or type of surgery that patients are having. And that can be really important. So these are ones, these are often patients that we are seeing. We have a multidisciplinary clinic where we're actually seeing patients together with the surgeons. And I think that can be really helpful too, to have those discussions.
Yeah, I'm so glad you brought in the concept of a multidisciplinary approach. I think for these patients, especially when we're trying to treat them with intention to cure, and we know that we're trying to tee them up for surgery and what to do after, we need to partner with our surgeons and also a radiation oncologist, because you never know when they may need when patients may need radiation therapy as well in addition to their management. And I think you hit the nail on the head, both of you, in regards to patients now with this neo-ADORA data that was presented and so exciting. We're giving patients, most of us may be considering giving patients osimertinib before they go to the operating room, and now, maybe plus or minus some chemo. But then I think, if they got chemo and they got OC after, before then they get their surgery, do they need more? And currently, I am following with the ADORA approach, which is offering patients osimertinib, but do you give them more chemo also? I think it's unclear, right? I don't think we really know that right now. So stay tuned for that. But I think if you are a patient with an EGFR mutation and you're heading into getting some kind of chemo before the operating room, please do ask your oncologist about adding osimertinib and what their thoughts are. There was a smaller study in the same space, just to kind of think about our patients with ALK fusions that are also on this call, called the AL-NEO study, that looked at giving patients alectinib before they went to the operating room. And it was very small and didn't get as much buzz as the neo-ADORA, but I think still deserves a little bit of a spotlight here. Are you considering offering neoadjuvant alectinib to your patients also based off this data?
So I think, go ahead, Nisha.
I was going to say we are lucky because we have a trial where we get to do that and we can help answer the question in a larger way. Again, it was an intriguing study to see at least what the major pathologic rate could be with alectinib. I don't know if I will say I'm not doing it off trial, and I'm lucky in that sense that I have that trial to offer patients. But I think the same concept of should we be introducing these drugs way earlier in the treatment course, or there's such strong data from Alina post surgery. So I think this trial definitely deserved some attention, but I think it was a phase 2, a little bit smaller, and trying to understand how to think about the whole paradigm.
Yeah, I agree. I mean, I think that it's less strong data just because it's a smaller, study that didn't have kind of the comparator arms that we talked about with Neoadora. But I will say, I think that the data was certainly encouraging. If anything, we see more major pathologic responses and more, still relatively low, but more pathologic complete responses with the alectinib approach in ALK-positive lung cancer that we're seeing with kind of the preoperative EGFR inhibitors. I think that, so based on this, I would be tempted, although I think it would require a lot of discussion. We also don't have data on, how to incorporate chemotherapy here. So this was really just looking at alectinib alone before surgery. So I think these are situations where we're really also discussing them in our multidisciplinary tumor board. But I will go out on a limb and say, I think that there's probably a subset of patients where this may be, something that would be considered before surgery, and then still thinking about the chemotherapy after and alectinib after if needed. I think these are complicated kind of situations that have to be discussed as a group. But I was encouraged actually by these data, and I think it's going to be hard to do large randomized studies in ALK and a lot of the other kind of oncogene driven subsets that are less than kind of smaller and smaller pieces of that pie. So some ways we have to extrapolate from one to others, but I was encouraged by the El Neo data, and I think, hopefully we'll have more from that study.
Yeah, I definitely agree. And I thank you for your insights there and your candor in a space that doesn't really have quite approval yet, but it's helpful to hear. So let's move away from the early stage setting and move on to talk about the advanced stage setting in non-small cell lung cancer. So patients with stage 4 disease that we're treating, with the intention to extend their survival and improve their quality of life. So I do want to jump directly to datopotamab deruxtecan, or Dato-DXd, which I see you're both smiling about, that just got FDA approval yesterday, which is really exciting, or may have been 2 days ago, actually, for patients in this setting with stage 4 non-small cell lung cancer harboring EGFR alterations. So this was a study based off TROPION-Lung02. And I'm just curious what your thoughts were on this release, this FDA approval. Are you going to be using this in your clinic, and who do you think is the right patient?
Yeah, I can touch on this. I think there's, as someone who does a lot of research in the space of patients with EGFR mutated lung cancer, I think it's always great to have more options. So datopotamab deruxtecan is kind of this new concept of treatment, this antibody drug conjugate, where again, you have an antibody that's targeting kind of a protein on the cancer cell surface, and it's attached to a chemotherapy. And the hope is that you deliver chemotherapy more selectively to cancer cells, and therefore, are more effective in kind of treating the cancer cells, and also hopefully have kind of lesser different side effect profile than standard chemotherapy. And datopotamab deruxtecan is being developed in lots of different spaces, but the first approval was for patients with pretreated EGFR mutated lung cancer. So this is just to say, this is a drug. The target is something called TROP2, TROP2, which is a protein that's expressed on lots of different cancer cells, lung cancer cells. And so again, that's why it's being developed in different contexts. But there has been data with looking at datopotamab deruxtecan in EGFR mutated lung cancer in patients who had already gotten an initial EGFR inhibitor like osimertinib or others, as well as had already gotten chemotherapy, which is kind of our other approved, carboplatin pemetrexed for these patients. And this is an accelerated approval based on kind of single arm data. This wasn't a randomized study, but we saw, I think, relatively kind of clinically meaningful activity. We did see, patients having tumor shrinkage. We saw some durable responses. And so I think this is certainly a good option for patients with EGFR. As with everything, we have to balance, I think, that the good with the bad. It does have activity, but it also has, I think, a relatively more unique safety profile. The kind of particular side effects that we have to be aware of with datopotamab deruxtecan. It can cause mouth sores, or sometimes we call that stomatitis in some patients, and there is guidance as to how to manage and prophylax that. There's kind of steroid mouth rinses. Yes, someone's asking me to repeat the name of the new treatment, datopotamab deruxtecan. We won't make you say that too many times fast. Maybe one of you guys can type it in the chat. There you go. So, so mouth sores can be seen, and we have to give prophylactic steroid mouth rinses. Ice chip therapy during treatment can be helpful, and being very proactive with management. Sometimes people can have some eye side effects that can be kind of bothersome that we have to watch for. There can be some hair loss or alopecia with this therapy. So that's another thing that for a lot of patients is an important treatment consideration. But at the same time, I think the effectiveness that we've seen in the clinical trials so far has certainly been at least at the level, if not higher than the level that we see with some of the later line chemotherapy agents that we have. And so I think that this is a great tool to have in our tool belt. I think another important point to keep in mind with this is that with some of these antibody drug conjugates, we are able to select patients by kind of testing cancer cells for the expression of the protein that they're targeting. So, for a TROP2 antibody drug conjugate, in an ideal world, you'd be able to test a cancer cell for TROP2 on a biopsy. And if it's positive, that drug would work well. And if it's negative, the drug wouldn't work at all. But unfortunately, the world is not ideal. And so for datopotamab, that TROP2 biomarker really doesn't work well at all. So right now, we're not selecting patients in that way. There's a lot of work being done to try to kind of develop better biomarkers to help us, understand which patients are most likely to benefit. But right now, for patients with EGFR mutated lung cancer who've kind of gone through the standard options that we've had available, I do think this is something that will be worth a discussion, and I think we'll consider it for some patients. I don't know what you guys, how likely you are to use it in your clinic.
I think, yeah, I think that it opens another option. I think that this whole EGFR space has been starting to shift around when we are using our drugs and we're using more things up front or the second line. So it has another opportunity for patients. I think from a patient perspective, it was nice to see that there was another thing approved, especially after the Herthena data that people were, thinking about. They saw that didn't move forward. So again, we get these balances of things moving forward and others not. Yeah, it definitely, as much as it is trying to be this targeted approach to delivering toxic treatment or, chemotherapy, we know it has other side effects. So I think the molecules will also continue to get smarter. And then we are also learning how to be proactive with managing side effects. So yes, I will use it after chemo and other standard approaches have been applied, but it's another door. And I think that's that was what was nice to see.
Yeah, I think I personally struggle a little bit in this space for patients with these alterations that, we're treating in the frontline setting now that we have these three options, and then what to do after they progress. So I guess if you have somebody in your clinic that is on, let's say, frontline osimertinib and unfortunately has progression, are you looking more towards like chemo and amivantamab? Are you looking to use datopotamab deruxtecan in this setting, or how are you sequencing that?
So I think right now, as you alluded to, and as we all are experiencing in our clinics, it's a complicated space for patients with EGFR mutated lung cancer, particularly, those that are initially diagnosed with advanced disease. We have basically, as you were saying, three options. We can think about osimertinib alone, which I think affords patients the least kind of invasive, the best quality of life. But then we also have two different combinations that add a little bit in terms of side effects, but also seem to, extend at least the progression free. And in the case of Mariposa, the overall survival. So we have, chemotherapy added to osimertinib as another option. And then we have the antibody targeting EGFR and MET that's called amivantamab, combined with a different but very similar EGFR inhibitor called lazertinib. And we discuss all these options. They're different ones are right for different patients. Certainly there are still some patients who, for whom the osimertinib alone is the best option. And lots of patients who started on osimertinib before these options became available and have been doing well on them. And for a lot of those patients, chemotherapy is our next best approach. And I certainly do think about chemotherapy with amivantamab for some patients. Again, you hear us saying over and over again, adding more drugs adds to the side effects of these therapies. And amivantamab in particular can add a lot of kind of skin side effects that have to be managed. But I think for a lot of patients, chemotherapy and amivantamab is a good option. Second line, I wouldn't, based on the data that we have with datopotamab deruxtecan, kind of supplant chemotherapy as our second line option. I think that it's still relatively early days, even though we're excited to have it approved. The approval is based still on, I think, relatively small data. We don't have a randomized study yet. These are kind of single arm studies. And while we're seeing encouraging data, I would say numerically looking across them, they're not kind of blowing our current standard of care out of the water. So for those reasons, I wouldn't use it second line yet. I still think chemotherapy or chemotherapy plus amivantamab is, the best second line option. But beyond that, if other clinical trials aren't available, I think that datopotamab deruxtecan is certainly something that I would reach for, or at least discuss with patients and think through the pros and cons. I will also say there's a number of other antibody drug conjugates that are being developed. Even at ASCO, we saw, other TROP2 ADCs that I think there's a lot of enthusiasm and excitement about. So I think the options hopefully will continue to grow. But it's good to have it. And I think as a third line option, it'll be something we use for some patients.
Yeah. And I think especially after a patient's progress on osimertinib or any of these targeted agents, it's important to think about what the mechanism of why it stopped working. And I think we saw, data there too at ASCO that there can be subsets where there is another mechanism that the tumor is using, and you can target that. So I think the biology is really important at different stages of that treatment to know what you do next. And I think in the chat there was something about thinking through molecular testing, and that's certainly so important first line before you start treatment. But I think it's also important that we don't skip that step for some of these patients as well as they progress, where we may be able to be still actionable.
Definitely, and I appreciate your transparency here about this, because I know these questions are going to come up, and I think it's just nice to have another option. But I agree. I don't think I'm ready to have this replace carboplatin pemi or some platinum doublet amivantamab in the second line setting just yet. You did bring up a study that unfortunately did not create as much buzz or positive buzz as we wanted. And I think while we spend so much time thinking about positive trials, it's really important to think about, trials that may not have resulted in something positive, but did teach us something. And that was the HERTHENA-Lung-02 study, looking at another antibody drug conjugate targeting HER3, patritumab deruxtecan. And I think there was a lot of excitement about this. We had this study at MSK, have had patients on this study, and patients that have been on this study are trying to digest, what happens? What's going on here? What does this mean for me? So what are your thoughts about this study that wasn't so fruitful?
I think that, I was really disappointed. I think we all were. We also, participated in the study. I think we're all hopeful that this would be yet another option for our patients. It's another but different antibody drug conjugate targeting a different protein, in this case HER3. I think that a challenge in this, again, is a theme that maybe we see in different contexts, is that if clinical trials are often done first in kind of later settings. So patients who've kind of already gone through some of the standard treatments, and, you're using it kind of in as a third or fourth line or later therapy. I think that when we see activity there, a lot of times there's enthusiasm to move those therapies to earlier lines of treatment, to say, hey, can we maybe do this right after an initial targeted therapy, or even sometimes as a first line initial treatment. And there's pros and cons to that approach. I think the bar is always higher, that the treatments that we have are more effective. So you have to do even better to kind of beat them in a head-to-head trial in a second or especially first line setting. I think also, the side effects are especially scrutinized, especially in that frontline setting. We see this a lot, when patients are on that initial treatment for a long time. Side effects are especially important there. But this, I think, was a case of a drug that had benefit. It works for some cases, but they compared it to chemotherapy, which frankly, sets a relatively high bar. It wish set even a higher bar. But what we saw is that the drug, I think, performed sort of as we would have expected, in that later line setting, but it wasn't good enough to beat chemotherapy. And, in particular, it wasn't kind of enough to beat chemotherapy in terms of overall survival, which is the marker that is being used. And so I think that as a result, unfortunately, that's going to mean for this one, based on the press release, that it's not moving forward in development. I don't think it means for patients who are on that study that it can't work in those later line settings, or that it's not an effective therapy. I think drug development has a lot to do with, where these drugs are positioned for, kind of those confirmatory randomized studies that ultimately lead to their full approval or don't. So I was disappointed. I think it was an effective drug, and I wish we still had it, but I think there will be other drugs coming, and we learned a lot from it.
Yeah, it's hard because when you have the trial, you definitely see patients that can benefit from that drug, especially for a long time. So I too wonder at some point if we will be able to select patient and tumors a little bit more thoughtfully. So we understand if there's some other way to identify the patients that would benefit, especially when we're trying these agents against the standard of care. Maybe it's a population of patients where they're really getting the benefit, and we're just not there with our understanding of it yet. So we're not seeing the benefit in the general population. So I was disappointed to see that, but like Zofia said, we learned a lot, and I think we continue to think about how we're going to learn for these next sets of trials.
Thank you. And I see our chat is coming alive again a little bit. There's a request for you, Zofia, to talk about the ADCs that you discussed at ASCO. And yes, would love to hear about that. And there's some questions about EGFR, TKI combining with Dato-DXd, which I think, I don't think that's ready for prime time yet, but that may be a direction that we're going. And thank you for the feedback. In regards to the antibody drug conjugates, I know we can definitely take a little bit of an aside. Zofia, is there an aspect of what you presented that you think you want to highlight that we could go over today, or do we want to leave that for the end?
I think maybe what they're referring to is when I said earlier that there were some other kind of exciting compounds that we saw at ASCO, and I would say that one that was presented, and I think it was the oral session, was sacituzumab tirumotecan. And again, sorry for all of these terrible names, but it's yet a different TROP2 antibody drug conjugate. When all of these drugs kind of in theory are targeting the same protein and bringing chemotherapy, there can be a lot of nuance to the exact antibody that's used, to the chemotherapy that's attached to the antibody, even to the way that these medicines are linked together and how they're kind of released within the cell. So there's a tremendous amount of nuance to the development of these antibody drug conjugates that has really important impact on both how they work and the side effects that they can cause. But sacituzumab tirumotecan was a new TROP2 ADC that was presented out of a study from China, the OptiTROP-Lung03 study. This was actually a randomized study comparing to docetaxel chemotherapy in a population of patients from China with EGFR mutant lung cancer. And I was encouraged by that data. I thought it looked pretty good. The response rates were relatively high. And their durability seemed to be pretty high. So I think this is, still a relatively new drug, and we need more global studies, but that's one that I'm personally keeping an eye on. And I think there are studies of that one coming online, not presented at ASCO, but, there's also a drug from being co-developed by Systimune and Bristol Myers called Isabel, which is a bispecific antibody targeting EGFR and HER3 and a chemotherapy attachment that's in clinical trials that, and there's many of these others, probably more than we have time to kind of list. But this whole class of antibody drug conjugates is something that, there's a lot of ongoing clinical trials, not just in EGFR by any means, really across the board. And I think they're ones that we're all, kind of keeping an eye out to see which ones show promising activity, but also, that show the best safety profiles as well.
Thank you for that. Yes, I think there's over 300 antibody drug conjugates that are in development right now. So you'll be hearing a lot of other MAB words probably at our next session. So I do want to just stay within the EGFR space a little bit because there's another novel tyrosine kinase inhibitor for our patients that harbor EGFR exon 20 alterations. So all of the EGFR alterations we had been talking about are those that have EGFR exon 19 deletions or exon 21 L858R insertions. But our patients that have EGFR exon 20 insertions have not really been privy to any of these drugs that really we've been talking about. Yes, amivantamab and mobocertinib, which has fallen out of favor. But it's so nice that we now have this data on zipalertinib, which is an oral tyrosine kinase inhibitor for patients that harbor EGFR exon 20 insertions. And love to hear from both of you what your take is on this data. Are we going to add this to our practice at some point? Let's talk a little bit about zipalertinib.
Yeah, it's exciting to see that we can, again, target these exon 20 with these oral agents. What was interesting from this was thinking about the sequencing of treatments. And a lot of the data is now post amivantamab and we have ongoing clinical trials with oral agents. So I think we're going to try to understand how to do these agents and in what order and what toxicity and what amount of time of benefit we're going to think through that. But yes, very exciting data to see that there was response and activity and that there was a really nice duration of response, again, in this space that has emerging new agents coming, and it's had a peppered past of having things approved and then taken away. And so I think it's exciting to see that we're getting some good agents back into this space.
Yeah, and I was an investigator on that zipalertinib study, so certainly I'm excited about this one. But I will also highlight that there's several others that are also in development that have shown good activity. I think really the hope is that we'll find drugs that are more effective, but also with some of these agents, we've seen that they're kind of cause more of the side effects that we can sometimes see when EGFR is the normal EGFR protein that we have in our skin and in our gut is inhibited, and it can lead to a lot of rash and diarrhea in particular. And so this next generation of exon 20 drugs, I think, is trying to improve upon that as well. So there's zipalertinib, there's sunvosertinib, and there's furmonertinib, and then there's a whole kind of next line of them that don't have an IB name yet. But there's a number of these trials in development, and I think it's really exciting to see, for patients with EGFR exon 20 insertions, what the options are going to be. I do think this is a time when, for patients who have EGFR exon 20 insertions, it is important, if it's feasible, for patients to explore clinical trial options. There's a number of drugs that I think are really encouraging and are not available kind of through standard approved pathways yet. So I think it's a space where there's a lot of activity and excitement, and hopefully soon there will be an approved drug. But right now, I think clinical trials are the best way to access them.
Agree. And I think anybody that has EGFR exon 20 insertions, it's so important to think about trials, regardless of alteration or not. Clinical trials should be used right up front, right off the bat, not used as last ditch efforts. We really want to move the research needle forward. So, even if you think you may not be a candidate, or even if your doctor has not talked to you about it, it doesn't mean you're not a candidate, and it doesn't mean that there wasn't anything available. So please speak up, raise your voice, and ask about a clinical trial at any opportunity that you can. Absolutely.
So important.
So moving on to different alterations, I know we only have 15 minutes left. We're going to try to cover the space of HER2 alterations. So our patients that have HER2 alterations, this is a different alteration than EGFR and ALK that we've been talking about. Typically, we have been giving these patients frontline chemotherapy and immunotherapy, and then we have trastuzumab deruxtecan, or TDXD, which is another antibody drug conjugate approved for these patients. But it's really exciting that, we're able to kind of dabble in the space of oral therapy for these patients, which I know there's a lot of different competing drugs out there in this space right now. But Bayer, or BAY292, which has now been given a name, cevabertinib, is an oral drug in this space. And I'd love to hear from both of you about your thoughts about, how do you navigate patients with HER2 alterations? How do you sort of frame these visits? How do you talk to your patients with these alterations? And how are you treating them, and what are your thoughts on these oral drugs?
Yeah. So I would say, I think this is kind of similar to what we were just talking about with the patients with EGFR exon 20 insertions, where there's a lot of exciting clinical trials ongoing. And I totally echo what you said earlier is I think every patient should at least ask whether there might be clinical trials for them. But I think patients with HER2 mutated lung cancer, it's also an especially exciting time. I think we do have a targeted therapy, but an antibody drug conjugate targeted therapy approved now with trastuzumab deruxtecan, and that can work really well for some patients, sometimes for quite a while. But now there are these, I think, exciting and really quite active drugs, oral targeted therapies in development. So there's cevabertinib and then zongertinib from Boehringer Ingelheim. I think those are the two that are kind of the furthest along. I think the data that we saw with cevabertinib at ASCO was exciting in terms of kind of the level of activity. The response rates were quite high, but it also did have, I think, a notable safety profile. I think there were relatively high rates of diarrhea, which is always something that, I'm mindful of because it can really impact kind of patient experience and quality of life. But it certainly was a very active drug. And so I think that it's one to keep an eye on. And I know that there's kind of ongoing trials, and including first-line trials for newly diagnosed patients happening. There's also zongertinib, which has also shown quite, encouraging activity and also has a first-line study ongoing. So I hope that over, the coming months and years, we're going to have kind of changes in our kind of sequence, more options available, but also I think right now, currently still today, it's chemotherapy plus or minus immunotherapy first. Then I think trastuzumab, which is approved only in that post-chemotherapy setting, the trastuzumab deruxtecan, and then these oral targeted therapies. But I do think that over the coming years, we're probably going to have access to some of these therapies in, the first line as well.
Yeah, I think again, same concept. I think these agents are having high response rates, and we are going to see some hopefully approval, coming soon. How we use them and in what order, I think is the most exciting thing that I think we are going to need to answer. Do we do these? Can we eventually get to these oral agents first and use, systemic and infusions for later lines? I think we're going to need to, we're not there yet, but I think that whole thing that we talked about, time toxicity and quality of life and all the hard decisions we make with EGFR, classical mutations, I think will eventually be conversations for this space. But first we have to get them in and tried and approved and moving along. So clinical trials are absolutely the way that we're going to know what to do.
Yeah, I think one thing that is also very interesting, you talked about toxicity, but I think one thing to kind of help us sort of parse between these zongertinib and cevabertinib, and there's also another drug that doesn't have a fancy name yet, but it's made by Nuvalent. I think it's NVL. It's either 330. I mix them up with 550. So NVL 330. Yes. Is there CNS efficacy, right? So the ability of these drugs to penetrate into the blood-brain barrier, because we know patients with HER2 alterations, much like EGFR and ALK alterations, tend to have a high propensity to develop brain metastases. So we know TDXD is kind of big and bulky, can't really get through the blood-brain barrier, and same with some chemo and IO agents. So these more ninja-like tyrosine kinase inhibitors have the ability to get into the blood-brain barrier, and I think that's something to keep front of mind. And, if you are somebody with brain metastases and a HER2 alteration, I would really push for these trials for you to get that drug to penetrate into the blood-brain barrier and address these, and maybe even consider staving off some radiation. So it's a thought. I see our chat is lighting up, and I just want to, there's a question here about, let's see, a patient, unfortunately, with an EGFR exon 19 deletion, advanced stage, helps when I meet with my doctor. Okay, great. So in regards to just moving on a little bit in our last couple minutes to the KRAS G12C space, this is an alteration that's very common. It's much more common than any of the alterations that we talked about previously on this call. Typically, it's seen in patients with a smoking history. And while we do have two FDA-approved oral drugs for these patients, sotorasib and adagrasib, in the second line setting, I think we are always trying to figure out, well, can we move these drugs to the frontline setting, and who does best with these drugs, and is there a role for combining these drugs with other agents without increasing toxicity, right? So there was some data from the Crystal-7 trial that looked at combining adagrasib with pembrolizumab and immunotherapy. If either of you were able to attend these talks, what were some of your take-home points? How are you helping these patients right now in your clinic?
Yeah, I think that the combination of these drugs with immunotherapy are being demonstrated in multiple trials, and there was an intriguing signal, especially in the PD-L1 greater than 50% population with that combination. The progression-free survival in that cohort really was intriguing. I think that when we are doing these trials, so again, I think your plug for trials is absolutely spot on. We're going to have to understand how to manage side effects and toxicity and make sure that we are maintaining the drugs that will have long-lasting benefit. But yes, this is a space that is emerging. We'll continue to see this combination of IO immunotherapy plus these KRAS-directed therapies, whether they're the established KRAS agents or even novel KRAS agents, are starting to really, make their way into this space. So I think more to come. I wouldn't do it off trial. I would definitely put a patient on trial, so not ready for prime time. But yes, definitely a signal worth exploring more.
Yeah, I think that it speaks to the fact that targeted therapy in lung cancer is not all the same. We have a lot of enthusiasm about some of these targeted therapies that we've been talking about, where they can be really, really, effective. They can have very high response rates, cause high rates of tumor shrinkage, and sometimes work for a long time. And while we're really excited to have drugs for patients with KRAS mutations, I think, which are the most common type of mutation that we see in lung cancer, in at least in the US, I think we can all agree that we have a lot more work to do. These drugs can work, but they don't work as well as some of the other targeted therapies, and they can sometimes have quite a lot of side effects. And so I think for both of those reasons, we need to do better. And sometimes doing better is by combinations, combining with other effective therapies. And sometimes it's by developing kind of the next generation of drugs that are more potent, more selective, have better safety profiles. And I think both efforts are happening. But I do think it speaks to the fact that we're really happy to have some approved KRAS G12C inhibitors, but I think we want to see drugs with better brain kind of activity. We want to see drugs that have less side effects. And then I would also say we also want to see drugs for other KRAS mutations besides G12C, because lots of patients have non-G12C mutations where we don't really have options. So, I think hopefully more to come on all those fronts.
Yes, thank you for that. I couldn't agree more. The alphabet soup of KRAS alterations definitely haunts me, and I'm looking forward to more approvals in that space. So we have about 5 minutes left, and there were some questions in the chat, but please feel free to put some more. There was a question that I answered about artificial intelligence, yikes, at ASCO. And I did attend a couple sessions in between, but very curious to see if either of you were able to attend anything and what your thoughts are about AI in general with oncology.
So I will say I wasn't able to attend the sessions, but I know there's a lot of exciting work being done. From my own colleagues here at MGH, there's been a lot of interesting work in kind of the early stage and lung nodule space, and trying to kind of incorporate machine learning and artificial intelligence into trying to predict the risk of lung cancer development based on kind of CAT scans, not even necessarily individual nodules, but kind of a broader look, an AI-based look at CAT scans. And, there's a lot of really, really interesting work looking at that. And the algorithm that's being developed here is called Sybil. But I think that, there's a lot of work around the world, I think, kind of focused on that. So I personally am really excited to see where this goes. I can't speak to it at a high level. It's not my area of expertise, but I think it's got a lot of potential.
Yeah, I agree. I mean, I think this year there was a lot of partnership. I think ASCO is even partnering to think about how to bring AI to the fingertips of more clinicians. But I think I learned a lot. So I think I learned that how something is trained and what data set it was trained on is very important. And as treatments continue to change so quickly, just ensuring that validity of the model still looks right. But I do think that there's just so much data, and there's probably nuance within the human body, the tumor environment, the gut microbiome. I think there's so much that we will need some kind of help to put it all together and make really smart decisions, and that could be a really nice tool. So I think we're at the tip of a really big iceberg of what's to come. And I think it's exciting to see, but I think it was helpful to hear some of the experts say, these are the things that you need to think about when you're adopting these models. And I think that was helpful because they are trained and then they have to, and our treatments continue to move forward. So I'm excited for what the future holds, but yeah, I got to learn a lot more on how to use it well and what to think about.
I fully agree, and thank you. Thank you for that. We have about 2 minutes left, so I think if there's no other questions, we can wrap it up and give you back 2 minutes of your time. And thank our amazing thoracic oncologists for joining us today and teaching me and all of us. Zosha and Nisha, you are incredible. And I thank you so much for spending your afternoon with us.
Thank you for having us. It was really fun to digest the data.
Yeah, thank you for moderating. Great session.